Hello, I hope everyone can hear and see me. Thank you so much, Darren. My name's Michelle Batty and I'm the manager of the European Reference Network, which we call EUROGEN, which focuses on rare urogenital diseases and complex conditions. It's one of 24 ERNs, which was set up by the European Commission in 2017. ERNs are essentially virtual networks which are connected by a secure IT platform which allows the safe exchange across countries and borders of medical information. So this system allows the healthcare professionals within our network to give highly specialised advice on patients with a rare or complex urogenital condition. So this way, it's the advice, it's the knowledge of the expert clinicians that can travel, and it's not the patient that needs to travel. So that's essentially what we're here to do, and we do encourage any healthcare professional out there, if you're facing a case which is particularly complex and you would like advice, a second opinion on surgery or the management of the patient afterwards, please feel free to contact us. We're here to help and we're delighted to do so. Now it gives me a great deal of pleasure to introduce Hanny Cobussen, who is one of the specialist nurse practitioners at Radboudumc University Medical Centre, and she's in the Paediatric Urology department. And we're really delighted to have a nurse who's come to talk to us, because it's really important for the patients that they can get access to this particular advice when they're dealing with perhaps children with a complex condition. So I think that will be it from me. Thank you everyone for joining, and I'm really happy to hand over to Hanny. Thank you.
Thank you for the nice introduction, Michelle. I have the following conflicts of interest. Let me shortly introduce myself. First as a nurse, later as a nurse practitioner. I have over 25 years experience in pediatric urology, especially in continence care. In 2016, I defended my thesis, Effectiveness of Urotherapy and Specific Interventions successfully. I'm looking forward to this online meeting. In this meeting, I want to discuss the following items with you: a short overview of the history, definitions, and in the first part, I will tell you something about IC via the urethra, and in the second part, IC and continence stoma. To start, a short overview of the history. Intermittent catheterization was reintroduced by Lapidus in 1972. It represented a urological revolution for patients with different diagnoses and bladder-emptying difficulties. Hannigan and others modified the technique later for children. Nowadays, the technique of IC is applied to all age groups, including newborn and older infants, and has become an important therapeutic tool in pediatric urology. The goal of teaching IC is to provide a bladder management program that promotes optimal health, self-esteem, and independence. Right from the start, nurses were involved in this treatment. And nowadays, in most countries, nurses teach and coach IC in patients. But where are we talking about? The definition of intermittent catheterization is the same for adults. Drainage of aspiration of the bladder or a urinary reservoir with subsequent removal of the catheter. The technique is overall the same, but for children as adults. But specific approaches are present for children and teenagers, which I will discuss later on in this presentation. Also, the definition of post-void residual urine and retention are the same as in adults. Post-void residual is defined as the volume of urine left in the bladder after voiding, and urinary retention can be subdefined in acute retention. The patient has a painful palpable and percussible bladder, which is unable to pass urine. And chronic retention of urine is defined as a non-painful bladder which remain palpable or percussible after the patient has passed some urine. When going a little bit more in detail, there are different IC techniques. The European Association of Urology Nurses has made a guideline in 2013, and at this moment it's going to be updated. And they found that the techniques are not always described in literature and are often used incorrectly. They made an overview of all the techniques described, and after discussing this in the working group, they decided to make a new overview, as shown in this slide. The European Society of Paediatric Urology Nurses adapted this new overview in their guideline. A complete sterile technique, as you can see in the slides, is only used in operation theaters. This technique implies that all materials are sterile. The person who carries out the catheterization wears sterile clothes, including sterile gloves. It's often confused with the aseptic technique. The aseptic technique, nowadays often with a non-touch technique, can be performed by the patient itself, healthcare professional or caregiver. In the hospital, healthcare professional uses gloves or an apron, and cleaning the genital is according to their protocols. The patient caregiver has to practice good hand hygiene, and the catheters are with a ready-to-use catheter or catheter sets. The clean technique is done in the home setting by the patient or his caregiver, and they have to practice good hand hygiene, where sterile, eventually with a non-touch technique, or a non-sterile catheter, sterile catheter is used alongside genital cleansing with water. Also, the ERN found that the abbreviations CIC and CISC are often used interchangeable. They stated that CIC is the abbreviation for clean intimate catheterization performed by caregivers, and CISC the abbreviation for clean intimate self-catheterization, and is used when a child or adult performs the catheterization itself. And at last, the term dilatation. This term refers to the condition when a urethral stricture or stenosis is narrowing the urethra, which needs to be stretched beyond its normal dimensions. This condition can also occur in children. The technique is the same, but depending on where the narrowing is, the catheter sometimes doesn't need to pass the sphincter. Often a more higher area of the catheter is needed. In children, the age of performing IC independently varies in the literature from 4 to 8 years, also depending on the cognitive level of the child. Also in literature, various ways of teaching IC to children are described, including drawers, instruction models, different kinds of devices, such as mirrors and catheters, using a step-by-step approach or training in a group. A relaxed approach, enough time, privacy, and respect for intimacy ease the shame and fear and facilitate memorizing of the information. Cooperation with a pelvic floor therapist or psychologist can be very helpful. In this slide, I have tried to visualize who can be involved in the care of children who need to perform IC during their life. A person who actually performs the IC, but also all other caregivers, peers or following sufferers and healthcare professionals who can be in some way involved. As you can see, a lot of people can be involved. And depending on the age or situation of the child, you have to take into account who should be involved or informed. One of the aims of the European Reference Network is to developing patient journeys. As shown in this slide, at this moment 4 are now completed. And new updates are coming and input is always appreciated. When looking at the bladder X-free patient journey, you can see that solving continence problems and taking care of quality of life are important issues during lifespan. And also in the ERN patient journey describes care needs beyond surgery should be holistic, lifelong approach to optimize childhood development, confidence and independence. So what does all this mean when starting instruction and coaching children and parents or caregivers? In children, parents and children or teenagers can perform the handling. So we will look more in detail to this. When parents have to start performing IC in children, often this is shortly after birth in children with, for example, spina bifida. This is an individual training at a ward or at outpatient's clinic. Before starting, information leaflets, videos, or websites need to be given or explained. Urodynamic investigation can be used to explain why they need to start. I often compare a normal bladder with a balloon and a high pressure bladder with an orange. Discuss further where to perform the IC at home. Preferable not in the living room. And also that it's an intimate handling and it's important to instruct only some family or caregivers they trust. Information leaflets for children can be used for older brothers and sisters and later on in life of the child to explain it to the child itself. We have an instruction model that parents can practice on before starting. Hygiene and especially hand hygiene and complications need to be discussed. Often in the early years, maintenance doses of antibiotic is needed, next to antimuscarine medication. Important to explain side effects of these, for example, obstipation, especially when starting antimuscarines, and what to do in case of problems or side effects and who to contact. At the start, a weekly contact and support by phone, video consult or email is needed. Explain why regular follow-up is needed. Parents are often anxious to start performing IC. Their child is so little and they already are faced with a lot of information and things to do. So they have a lot of questions regarding the frequency, the future, how to arrange it with work, in severe disabled children, who's going to do it and who is do it when it's grown up. Is IC still the best option in the future? And who and how to contact in case of problems. Try to give this information, but some issues only in general, because parents cannot oversee all the items at start. It is too much. In following up, attention needs to be given to these items, and maybe new questions or difficulties will arise. Sometimes IC is not possible due to social circumstances or due to abnormal urethra or a very bad bladder. Home care nurses can be involved in the care of IC, and sometimes when this is not possible, a vasostomy can be the best option. In the guideline of the ESPN, in more detail is described what needs to be discussed before starting IC. And also an appendix about suggested step-by-step approach is available to instruct parents. When children have to start performing IC, as stated earlier in this presentation, the age varies, but mostly it's from the age of 8 years and up. The child has to motivate it to perform IC itself and has the discipline and attention to do this at agreed times. Especially in children with spina bifida or children with attention problems, this can be a challenge. When a child is catheterized by his parents for years, some parents teach the child and we look at the outpatient's clinic once if this is correct. Some children will never be able to perform IC due to severe continence, cognitive problems or physical impairments, and then you have to discuss what is possible. Sometimes a bladder reconstruction is needed with or without a continence stoma. In the second part, I will tell something more about IC in continence stomas. When surgery is needed, this is important that a complete multidisciplinary team agrees, including child and parents, and that the child has practiced IC before the surgery and has demonstrated that she is capable to do this on fixed times. Also, bowel problems need to be assessed. Sometimes a combined surgery is done, and in specific cases, even an incontinent urostomy can be the best option. Information leaflets, YouTube websites can also be used for instruction, but also for example, explain to family or school. Even if children are catheterized by their parents for years, the child often finds it difficult or is anxious to learn. A step-by-step approach, sometimes with the help of a psychologist or pelvic floor therapist or both, is preferred. Important that sometimes children who are depending on caregivers never have touched their genitalium. So sometimes this is the first step to start. We also use an instruction model in children, where the child can practice all the steps. Mostly, we first practice lying on a bed, and in a later session, we practice on the toilet. Often more sessions are needed, or hospitalization for a couple of days, especially in case patients living far from the hospital. A group session can be an option for information and to meet fellow sufferers. And after the training, a diploma and a reward can be given. Again, in the guideline of the ESPN, a suggested step-by-step plan is available for girls and boys. A separate slide about teenagers. The flowchart is in principle the same as in children. The teenagers have and often want to become more independent. Transition is an important issue to start or to intensify around this age, because specific issues can occur. Parents find it often difficult to give their child more responsibility. So this is also something you have to discuss. But like, for example, compliance. We have parents who call us because they notice that they have to order less catheters as before, but the teenager denies. Teenagers who go to the toilet, open the package, and then throw it in the trash. Teenagers who keep beautiful frequency volume diaries and say that everything goes perfect, until they come with problems and turns out that everything was made up. Some teenagers choose consciously not for treatment which needs IC, for example, a bladder reconstruction or sphincter closure, and want to have diapers or incontinence material for the next couple of years. But also questions about who need to know in this phase of life are important issues to discuss. And of course, intimacy and sexuality are also issues which need to be discussed. Of course, a slide about materials cannot be missed in this presentation. There's a huge market with different kinds of IC catheters. There are catheters with a hydrophilic coating, a gel coating, or no coating. In some countries, catheters are for multiple use. Also, there are specific aids, like different kinds of tips, mirrors, or all-in-one systems. And also in literature, there seems to be a preference for hydrophilic catheters. Overall, the choice for a product depends often on patient situation, availability of catheters, and reimbursement systems. If you want some more background information, ask the ESPN for the guideline. Okay, when there are bladder-emptying problems in neurological, functional, or pediatric patients, IC is the golden standard with or without additional treatment, as we already discussed before. But if intermittent catheterization, self-catheterization via the urethra is not possible, there are other ways to ensure bladder emptying. A vasectomy can be placed. An indwelling catheter, transurethral or suprapubic. Not preferable in children, but sometimes may be an option if life expectancy is not very long. An incontinence urostomy, like a breaker, or a continent urostomy. A continent urostomy or catheterizable channel can be made of different tubes and techniques. The most common are the Mitrofanoff and the MANP. The Mitrofanoff is a channel made of the appendix, and the MANP is a tubulized channel of the ileum. Also, other tubes can be made like tubulized channels of the bladder wall or bowel of the augmentation parts. There are also other techniques like cock pouch and Indiana pouch, but they are not very often done anymore in children. Sometimes additional surgery is needed, like an augmentation, cystoplasty of a pouch, or a urethral surgery like a sling or bladder neck closure. The stoma location can be in the umbilicus or in the right iliac fossa. And very important is that the child has to perform intermittent catheterization every 3 to 4 hours, 4 to 6 times a day for the rest of his life. The decision for this kind of surgery always needs to be discussed and prepared thoughtfully with the child and parents. The inventory why I see via the urethra is not possible or too invasive. For example, is there an impaired hand dexterity? Is there a wheelchair-bound girls, difficulties to undress? Is there an abnormal urethra, trauma, extreme fear? How is the urine volume during day and night? But also the cognitive functions, especially in spina bifida patients. If healthcare professional will be lifelong needed, is this the right option? And how is the physical condition? For example, if the child is obese or is there a scoliosis? A correct place of the stomach can prevent IC problems, so this is something you should look at it. And if the child has limited hand dexterity, is IC in this way possible? For example, can the child open the catheter package and perform IC in this way? Or does the child still need help? Are there problems with defecation? If incontinence, is this operation an advantage? Child and parents have to realize that after the surgery, a diaper and IC is needed then. Is there maybe a need for combined surgery? And what are the daily activities of the child? Are there challenges or benefits related to the surgery? And if a young woman think about children, if they think about children, is this the right moment to do this surgery? After the inventory, child and parents need to be informed about the surgery of a Mitrofanov or MANP and possible additional surgery, treatment or medication. Where will or can the stoma be placed? Together with the child, parents and surgery, see if it's the correct place. If placed on the iliac fossa, the stoma site must be marked before the operation. Also, a bladder augmentation must be done. They need to know that the bladder needs time to increase in capacity in the first weeks and months, and that the suprapubic catheter also is needed for a couple of weeks, months. Explanation about long life IC and that the bladder should not be overdistended when an augmentation or pouch is done. Patients need mostly longer catheters, also women, so the urine can flow easily into the toilet. Attention for latex catheters in latex allergy in some patients, and discussion of defecation as mentioned in the other slide. Also, practical aspects need to be discussed, like fluid intake, hygiene, self-management, relations, intimacy, sexuality, daily activities, and pregnancy. And in pregnancy, discuss the need for a cesarean section, but also that the continence stoma can give catheterization problems during pregnancy. Well, there are also some complications which can occur, and I will discuss them in the slides later on. And also refer to websites of patients' organizations for further information. This kind of surgery should always be a patient-shared decision with a multidisciplinary team, which consists of at least a pediatric urologist, a surgeon, a nurse specialist, a psychologist, and of course the child and parents. It takes time to discuss and prepare the child and parents. Child and parents find it often a difficult decision, and difficult at which age they want to do the surgery. So carefully and honest information must be given. Children and parents must have the opportunity to talk to family sufferers. And of course, afterwards, follow-up care is needed long life. The most common complications, as you can see on this slide, I will discuss in the following slide. Stenosis. In case of a stenosis, an A stopper can be useful. Depending on the point where the stenosis is, there are difficult lengths of A stoppers. They also are difficult in flexibility. In case when you are not, you cannot order these A-stoppers, you can also a knotted catheter tip is described in literature to be useful, as you can see on this slide. Specific catheters can be tried, or smaller size can be tried. Different positions can be tried, like laying or sitting and pulling on the belly in case of obesity. Sometimes an indwelling catheter is needed for a few weeks, and important is not to fill the balloon so that the system cannot be damaged by the balloon. And at last, if nothing of the above tips helps, sometimes surgery is needed to resolve or dilate the stenosis, or surgery with mucosa has to be done. In case of a false root, also specific catheters can be used. Sometimes extra lubricant can be added. Try different positions, same as in stenosis, and discuss the teaching technique. When children perform IC for a longer time, they can do it sometimes a bit messy and too quick. And again, sometimes an indwelling catheter for a few weeks is needed, or additional surgery. In case of incontinence via the stoma of the urethra or balls, always exclude urinary tract infection. Sometimes increase of IC times can help. Additional medication like antimuscarines or botulinum toxin can be helpful in some cases. Of course, take care of stoma material, stoma plasters or incontinence material. And sometimes surgery of the stoma is needed, or additional surgery with a sling or other surgical techniques via the urethra. Fistulas, bladder perforation and stones are acute but rare conditions. Bladder perforation can occur when bladder is overdistended, and there is need for emergent drainage and sometimes surgery. Bladder stones are more common when staples used in an augmented bladder, but also because of the mucus, which can cause UTIs and in the end bladder stones. An ultrasound, X-ray or scan is needed, and a lithotripsy or lithotomy is needed if there are stones. Mucus, due to the bowel segment, can be a huge problem and can cause UTIs and blockage of the catheter. And this gives residual urine, UTIs, stones, UTIs, etc., etc. So flush with a syringe. Flush with aqua or saline until the mucus is over. Sometimes you can acetylcysteine dissolved in aqua can be tried. Special catheters with big eyelets or more eyelets can help to remove the mucus easier. And there is some research that stated that diary consumption can increase the mucus population. So maybe avoid if they use a lot of diary. At last, one of the most common problems in continence stoma, the UTIs. Important to do a culture in patients with a continence stoma. Is there bacteria or multi-resistant bacteria or fungus? Antibiotics treatment only in case of positive culture and complaints to prevent antibiotic resistance. Sometimes daily antibiotic is needed for a while. And is there mucus? Well, you can solve it as discussed before. Sometimes add cranberry or advise a low-carb diet. There's no evidence, but sometimes you can see that it reduces UTIs. Allergy and resistance for antibiotics are major problems, so it's important to try to look if you can solve the UTIs in another way. When discuss the literature about continence stoma, you can see that it's a diverse patient group. Different surgeon techniques are used, mostly out retrospective studies. Experience of the surgeons is important. Follow-up time differs, and there are a lot of loss to follow up. It's not, for me, it's not clear if all complications are recorded, but the complications reported are recognizable for me. Quality of life is also not looked very good at it, but if I look to my own patients group, you see that a lot of patients are satisfied with the continence stoma despite of complications, which can be, as you can see in the literature, can be common. But if they say if the complications are not too high, they are very content with the continence stoma and prefer it not to be incontinence and depending on incontinence materials or, for example, a brachistoma. There are some new developments. One of them is the Senju Novio scan. It supports school-age children who are dealing with bladder problems. It's a wearable ultrasound wireless with a discrete notification, and it offers personalized insight to recognize and act upon a full bladder. Intended for children from 6 to 12 years with bladder problems, and in children with neurogenic bladder for volume-based intermittent catheterization. There is a small study done in Belgium that shows that it can be helpful, but children should be independent. There are also the new surgery techniques. There is tissue engineering, and also new catheter material still is coming. So the take-home message of this presentation. When taking care of children who need catheterized, a multidisciplinary team is needed. IC can be taught individual or in a group setting, and a step-by-step approach is preferable. Often more sessions are needed. It's important to take all the time needed before surgery, and long life share and care is needed. On this website, some websites who can be useful. And then I want to thank you for your attention, and I will ask if you have some questions. I try to answer them. Thank you.
Thank you, everyone. I hope everyone could hear that okay. I think some people reported it a little bit low. Hanny, are you okay to start sharing your video? Hi, that's great. We're able to see you now. I think hopefully everyone can see you. I think I'll stop sharing my screen. So just before we take any questions, we've had one come through that I've sent on to you, Hanny, already. I'm just going to do a couple of quick polls for everybody. So just hold on 1 second while I get this launched. So we're going to ask the first one about just what your profession would be interested in. We have it on some of the registration reports. It'd be good to know who those here. Just trying to launch it now. So hopefully everyone can see that. So you can just click kind of one of those options. I'll give you about 15-20 seconds to do so. I'll just wait for the numbers to settle down. I thought we'd done there. No, still some changes. Okay, 4, 3, 2, 1. Close the poll. And those are the results. Okay, and then the second poll. Just interested if you're involved in teaching IC by continence stoma. So again, we'll give you about 20 seconds or so to fill this in. Okay, still going a little bit. Just about there, I think. Okay, I'm going to close it now. Show the results on that, so you can see these, Hanny, hopefully. Okay, I'm not sure if that's what you're expecting, but you can say. Okay, I'm going to hide those again and hand over to you, Hanny. So basically, if you've got any questions now, please don't hesitate to send them through, and I'll also send them on to Hanny. I think, can you see the question I sent you, Hanny, or not? Are you on mute? Sorry, still.
No, I don't see a question.
Okay, so I can try and read it out. I'm not, apologies if I get this wrong. So it says, hi, what do you recommend in patients with hand mobile alterations or paraparesia without fingers mobility? Sorry, okay, yeah. Does that make any sense?
If I understand it correct, what do I advise in patients with hand dexterity and paralyzed? I think.
Could be that, yeah. Without finger mobility.
Yeah, it also depends if it is a girl or a boy, and if it's via the urethra or via the stoma. But there are some specific catheters with some age you can try. Sometimes, for example, if they have problems with opening the package, you can try if they can open it with their mouth, or maybe with one hand and lay it on the legs and put the bed's hand and open it with the other one or something like that. So it's always very patients depending what is possible, and sometimes we also ask a specialist, and we call it in the Netherlands an ergotherapeut. I don't know how you call it in English, but somebody who has an education and they can make some alterations for can make some specific aids specific for one patient. Often they are working in a rehabilitation center, but sometimes it's difficult, and sometimes you have to see what's possible. I hope this is the answer I hope you can do something with this answer.
Yeah, thanks for that, Hanny. I should have said that was from Sebastian Gonzalez. Thank you, Sebastian, for that question. If anyone has any other questions, then please send them through now, I guess. While we're waiting, if everyone wants to do that, I'll explain that. So apologies again if anybody found the volume a little bit low. We didn't have much time to do testing on this, unfortunately, this time. But what I'll do, we will upload the video to the GoToWebinar platform and also to our YouTube channel. So I will look at just looking at the video and upping the audio if I can before doing that. So feel free to watch it back on those platforms. Yeah, we'll also kind of please check out our website for future webinars. The list on the next 4 or 5, I think, are on there at the moment. Not necessarily registration at the moment, but the next one will be set up in the next few days for the end of November. Yeah, so please check out our social media channels to keep kind of up to date with all the webinars we are organising. We're planning to try and do 2 a month from pretty much not in December, but from January onwards, still doing 2 a month now rather than 1. So yeah, you can find details on our website. We'll advertise them through Twitter, LinkedIn, Facebook, etc., as well. So please do join those if you're interested. You can also subscribe to our newsletter, which you can do through our website. If you go to the website and look in the top left-hand corner, you'll see a subscribe button. You just fill in your details there, and the newsletter comes out monthly, and it will have details of webinars and all the other things that are going on within EUROGEN as well, which you may find interesting. So yeah, so no more questions come through, Hanny. So I will say, everybody's got any questions, maybe if they want to watch anything back again and then have questions after that, please don't hesitate to send the questions to me. I shall pass them on to get an answer for you. So Sebastian's asked another question, just as I was saying that. So, but yeah, I will, anybody wants to ask questions later, please do, and I will send them on and we will provide you with a response as quickly as we can. So I'm just going to read this out. Sebastian's asking, do you think that spastic patients need stomas? I think that should be just stomas, yeah.
Well, I think it always should be a discussion. So that's what I try to explain in this presentation, that that you have to be give a good information, and together with the patient and the caregivers or the parents, try to discuss what is the best option for now, but also for later in life, because sometimes a stoma like a brachistoma can be the best solution. So, but it's always something you have to discuss and make a patient share decision of it. But yeah, well, I think that is something you should really discuss, and also give us an option, but really discuss. And sometimes we always involve also the psychologist, so that she also can talk to the patient and his family and put everything together and discuss a lot of stuff around what is important for the patients, how does his life look, who's depending on, who's taking care of him. So, but sometimes it can be the best solution. Yeah.
Okay, thank you. Yeah, so I'm just going to give all like 20 seconds or so to ask anything else you want. Otherwise, we can draw this to a close for today. And I said the recording will be made available in the next couple of days. I will send an email to all registrants with some details on for that. So please look out for it. We'll also be sending, you'll also get a survey, webinar survey to fill in tomorrow. I think it'll be 24 hours after this. So it would be really helpful if you could fill that in for us. Hopefully, you don't fill everything in just as much. If you've got any comments, please let us know. So we're just looking to improve these things all the time, and we need to do that by getting feedback from you guys. So thank you very much. If you could do that, that would be great. So yeah, no other questions. So I'm going to say thank you very much to Hanny for having done this, and thank you for everyone for joining. And please to look out for our future events, and hopefully see you all again soon. So thank you very much. I'm going to end the webinar now. Thank you. Bye.
Thank you. Bye.